All right, welcome everyone. It's the top of the hour and we're going to go ahead and get started with today's webinar. Welcome to the MIPS Tips session on looking at cost and year-end readiness. So I'm Natalia Wayne, a project manager with Comagine Health, and I want to thank you for spending time with us today. We have three wonderful presenters. We have Jeff Sabatka and Seema Rathor from Comagine Health and Sharon Phelps from Mountain Pacific Quality Health Foundation. And MIPS Tips webinars are really a collaborative effort between the three organizations that are named on this slide, with the goal of providing clinics and clinicians timely information on the quality payment program and to give you a chance to ask your questions related to this program. So between Comagine Health and Mountain Pacific, we support practices in a variety of states. Just a few housekeeping items before we get started. Please take a moment to locate the chat feature in this webinar platform. Links to the resources that the presenters share will be posted there throughout the webinar, and this webinar is being recorded. The resource links shared through the chat, a link to the recorded webinar, and a copy of the slides will be shared with attendees and registrants in an email that follows the webinar. If you would like to download a copy of the slides so you can follow along with today's session and take notes, I'll put a link in the chat where that can be located. The slide deck and recording will also be available on both the Comagine Health and Mountain Pacific websites following this event, and you can find the slide decks and recordings from our prior webinars, along with a lot of other valuable QPP resources there as well. So please make sure and visit those resources on the websites. We have very experienced presenters today that will be going through a lot of information, and we want to make sure that we're answering your questions. You'll remain on mute throughout the webinar, but you can use the chat feature to interact with our team and the presenters. So please feel free to share your thoughts, comments, and questions with the entire audience. Most of our team will be monitoring the chat throughout, and we'll bring your questions forward to our presenters during the moderated Q&A at the end of today's session. Your feedback is very important to us. So when you leave the webinar today, we ask that you provide your feedback on how we did and on topics of interest to you for future webinars. So watch for the evaluation survey link and take a moment to fill it out. Thank you in advance. To start us off, we're going to spend a few minutes with our expert, Jeff Sabatka from Comagine Health, and he will cover some important MIPS tips to note for 2020 before we start to cover costs. I'll turn it over to Jeff.
Thank you, Nat. MIPS performance is measured through the data clinicians report in 4 areas: quality, improvement activities, promoting interoperability, and cost. These 4 performance categories make up your final score. Your final score determines what your payment adjustment will be, if any. MIPS was designed to tie payments to quality and cost-efficient care, drive improvement in care processes and health outcomes, increase the use of healthcare information, and reduce the cost of care. The next slide. This chart shows the weighting of the categories as a percent of the total score. These percentages can change based on whether or not you've applied for an exception. I will talk about that in a moment. The first, next slide, please. The first MIPS tip is to be QPP portal ready. If you are not in the habit of logging on to your QPP portal regularly, you need to confirm your user ID and password. The password resets after 60 days. So if you have not logged on since you last submitted your data, you should get your password reset. Put that on your to-do list because it will require a call to CMS. As a security official, you can give access to others who may be involved in information collection and submission. And we always recommend you have at least one other person authorized to log on in case there's any issues. If you are new and do not have a user ID, you should get started working on getting your portal set up. For some individuals, getting the QPP portal set up can be a challenging process because of the security features. And if you need help from the CMS help desk, it is better to do it now instead of during submission period when they are inundated with requests and the wait times are long. Once you've confirmed and logged on, go back and check eligibility status with your link provided in the clinician's NPI number. If your vendor is submitting for you should always log in and confirm the validity of what they submitted. The next MIP tips has to do with extreme and uncontrollable circumstances. The application for those exceptions can be found on the link on the slide. You can apply for the hardship exceptions through your QPP portal. What is extreme and uncontrollable? They are the events that cause you to be unable to collect and submit information necessary that would be used to score a MIPS performance category for an extended period of time. For example, collecting data for quality performance category for 3 to 4 months. And one of these is COVID has definitely been an impact. Or any event that impacts your normal process affecting your performance on cost measures and other administrative claims measures. And just this morning, FEMA designated Oregon wildfires as a national disaster, and CMS has determined this policy will be applied to Oregon eligible clinicians that are impacted. The COVID-19 exception application allows clinicians, groups, or virtual groups to submit an application requesting reweighting of one or more MIPS performance categories. The PI hardship exception has a deadline of December 31, and if you're a small practice, have a decertified EHR, or have uncontrollable vendor issues, you qualify for the hardship exception. You do not have to report for MIPS PI, and the 25% will be reweighted to 0% of your final score, and the score will be redistributed to the quality category. Next is our registries. Registries collect clinical data from clinicians and report this data to CMS on their behalf for the purposes of MIPS. CMS requires them to be a qualified clinical data registry, or QCDR. And there's a link on the slide, or so you can go check which QCDRs are qualified. A QCDR is a CMS approved vendor that may include specialty societies, regional health collaboratives, large health systems, or software vendors working in collaboration with one of these medical entities. QCDR submissions differs from qualified registry submissions in that QCDRs can submit non-MIPS measured, called QCDR measures, as well as MIPS quality measures. They also may submit data for promoting interoperability and improvement activities on behalf of the clinicians. So the last two I want to talk about are the promoting interoperability and quality. The first one is promoting interoperability, and it's a 90-day look at your year. So we recommend you go back and find and look at the best 90-day period for your score, because you always want to look for the best, the highest score you can get. So you can go back through the year and pick certain 90-day periods. The second piece is the security risk assessment, which is now on its own with MIPS. It's not tied to the promoting interoperability. And this is critically important from a HIPAA perspective, security perspective. And the government, the OCR, really looks very closely at this. So we highly recommend you do this, and you make sure you dot all the I's and cross the T's, because you will get that will be a definite audit piece. Make sure the EHR is 2015 certified. You can't submit this year without that. That should be fairly obvious. I would go through and review any zeros in the numerator and verify if there's any exclusions. You can obtain documentation from any other registries, the public registries, that may validate your exclusion. Speak with your EHR vendor to see what kind of assistance they provide in the submission process, and know how to pull a promoting interoperability report from your EHR. Lastly, quality measures. Again, they're a full year, and they require a data completeness component. Check the denominators, review the measures with 0 in the numerator, look for data completeness. Like I said, you will need to report performance data for 70% of the patients who qualify for each measure. Each measure is reported on at least 70% of eligible cases over the entire year. That's all insurances, per the denominator criteria published for each measure. The last slide is just a reminder of the key dates. Again, December 31st is the end of the submission year. And it's also the last day you can apply for any exceptions. And January 4th this year is the first business day to start your submission for 2020. And that submission time ends on March 31st. One thing to remember, you can resubmit and go in anytime during that period and make a change if you need to. So it's always important to not only have that login and be aware that if you have your vendor or someone else submitting for you, you can always go back and change and then make and any sort of changes could be made before March 31st. So I'm going to now pass this over to Seema, who will talk about the cost component.
Thank you, Jeff. My name is Seema, and I am going to present on a MIPS feedback report, mostly focusing on cost category. So what is MIPS feedback report? MIPS feedback report is a summary of the data which you have submitted to CMS. It includes measure level performance data and scores. Then it goes by category, how much you have scored in each category, the weights, any extra bonus points. Then it tells you your final score and any payment adjustment in terms of percentage. Next slide. So who receives feedback report? Any MIPS eligible clinician who have submitted data or who have opted in, who have decided to opt it in, practices that were eligible at group level and have submitted data or have opted in, virtual groups. One thing is that those who have voluntarily reported will not receive feedback, payment adjustment, but will receive performance feedback. Next slide, please. So you can access your performance feedback through the Quality Payment Program website by signing in with the same credentials that allowed you to submit the data. Next slide, please. From Performance Feedback Report, click on View Practice Detail to access the overview of the scores. Make sure that your TIN matches, TIN number. Then on the left-hand side, click on the cost to view the cost report. Next slide, please. So before we go into detail in the cost report, I would like to just quickly review the cost measures. Some say there are 20, some says there are 3, depending on how you look at it. So number 1 is Medicare spending per beneficiary measure. For 2020, this measure has been updated, called as Medicare spending per beneficiary clinician, and the attribution methodology has been refined. If you have been in our previous webinar, we have really discussed in detail how the attribution methodology happens for all these measures. If you have more questions, please contact us and we can give you one-on-one time. Second measure is total per capita cost measure. This measure is very important for specialty providers or primary care, internal medicine. Again, this for 2020, this measure has been refined. There has been change in attribution methodology. And in that process, certain specialty providers have been excluded from this measure. And refined risk adjustment has also been changed. Previously, it would just tell you for a year, but now they have changed it on monthly basis to give you more accurate cost. Then they have added 10 new episodes, making it total 18 episodes. And mostly episodes is for specialty providers because they have been excluded from a total per capita cost measures, certain specialties. So just keeping all these specialties in mind, this is how they have, CMS have decided the cost measures. Next slide, please. So what is total per capita cost measure? This measure assesses the primary care clinician's overall care for a Medicare patient during the performance period in terms of dollars, because we are talking here of cost. It is payment standardized, risk adjusted, and specialty adjusted. What this means? So payment standardization means that CMS has taken into account payment factors that are unrelated to care of the patients, like geographic variations. California is more expensive than Oregon. Add-on payment for medical educations for universities. Then risk adjusted. This accounts for beneficiary level risk factors that can affect medical costs regardless of, doesn't matter how good you take care of the patient. Here is where HCC coding, hierarchical coding becomes very important. And third is specialty adjusted. Oncology is more expensive than primary care. So what they do, CMS takes all this into account on the back side, and they do certain calculation, and after that you receive the points on the cost category. Clinicians or groups have to meet minimum case volume of 20 patients to qualify for this measure. This measure includes Part A and Part B claims, so cost of both Part A and Part B cost. Next slide, please. So once you go into the cost report, there are various measures you would see. Today's focus, we are going to focus today mostly on total per capita cost measure, because that is what I have been seeing a lot, and that's where we are getting a lot of questions and some questions of the episode measures. Here we will discuss, on this slide, we will discuss the various elements on the total per capita cost report. The first one is total per capita cost average per beneficiary. This figure represents your performance on the measure from which the cost scores are determined. These are risk adjusted, specialty adjusted. Remember in the previous slide, we talked what those means. Basically, this tells you how much per beneficiary costed you. The next is measure score. This is the number of the points you earned out of 10 of this measure. Then below is eligible beneficiaries. Based on attribution methodology, eligible beneficiaries are the numbers of beneficiaries whose costs were attributed to your practice, your NPI or group NPI, however you have submitted. Then next, below that is total per capita cost and adjusted per capita cost. This figure is the average actual cost. This is not adjusted. These are the raw data, raw dollars. They do some kind of adjustment, but not specialty adjusted or risk adjusted. So this is very raw data. Then the next one is total per capita cost ratio. This is the average cost per beneficiary at your practice, which is divided by the national average. The total per capita cost per beneficiary ratio, if it's less than 1, means that your cost is less than average, which means it is pretty good. And unfortunately, I don't have the screenshot, but in the report, there are various nicely done graphs, which tells you how you stand in terms of national ranking. So look at those, and those are very well done, I would say. On the left-hand side, you see download beneficiary level data. If you click on that, there's an Excel sheet which you can download and save it for your further analysis. Next slide, please. The report includes, the Excel sheet which you will download includes a lot of information. However, I would like to focus on few of the important elements of the report due to the time constraints. If you have further questions, please contact us. So the report has beneficiary ID, type, sex, thin NPI, this is very important because this will tell you which patient is attributed to which NPI, and then you can see the cost, and then we'll talk further in the report that it will tell you cost, the sickness of the patients, and you will see how all the dots connect. Then measure would be obviously in this case for the per capita cost measure. Date of birth, I do get a lot of questions on this one. Patients is not 65. Why is patient showing on my report? It's because patient is on disability. So that's why it's on the report. Next slide, please. On this slide, we will focus on two of the important elements. This is also a part of total per capita feedback report. So two elements are hierarchical condition category, HCC percentile versus scale cost. So what is HCC? First, let's talk about what is HCC scores, and then we'll talk about percentiles. So CMS generates HCC scores based on beneficiary characteristics, such as age, sex, prior health conditions identified on previous Medicare claims. So what happens is that's why I keep on saying HCC coding is very important. Based on those, every patient puts in the rank somewhere between 1 to 5. That is HCC scores. Then these patients are ranked from higher to lower points, and then the percentile ranking is applied. HCC point tells you how sick your patients are. The percentile shows beneficiaries' risk or risk sickness compared to the other beneficiaries nationwide. Higher percentile ranking tend to be associated with more serious condition, whereas less is with less sickness. For example, ranking of 83 means that 83% of the beneficiaries nationwide had a lower risk. Second is total per capita cost. This tells you the amount of cost incurred during the performance year. It is not risk adjusted, not specialty adjusted, very raw data, true dollar amount it tells you. Now you have these two information. What do you do with this information? So we know that the patients in the higher percentile are very sick patients, maybe very old with multiple chronic disease. It might be very hard to move the needle on this population. The beneficiaries may, population in this, say for example, percentile somewhere 80 to 99, these beneficiaries may benefit from very intensive efforts to manage their care. Second scenario could be if we consider the population in middle percentile, say somewhere 50 to 70. We know that this population is not very, very sick. We might be able to move the cost needle by certain activities like coordinating the care with the other providers, providing self-management classes, providing rehab classes for cardiac patients, for COPD patients, some kind of remote monitoring. So we know that we might be able to do something for population in this category. There's a third possibility in this screen on this slide. If you see third row, HCC percentile ranking is 17, which tells you patient is not very sick. But if you look at the scale cost, which is 11,000 plus, so what is happening? Patient is not very sick, but then where is patient costing all this money? Is patient using unnecessary ER? Or are there duplications or lab? If patient had a fracture of hand and if patient has to go to ER, that is totally different issue. But this is how you can think of this cost report. Then there is one more category. Say HCC percentile patient is at 90. We know that patient has a lot of chronic disease, but scale cost is very low. Maybe patient was doing very well all these years, but you can think that the high cost of this patient may be incurred in following years. Can you flag these patients in your system as a high risk, or can you enroll them in intensive care management? Something, you might want it to start thinking beforehand. So this is how I see this data to do the ways to analyze. Next slide, please. So like I mentioned, there's a lot of information. I'm pointing out some important things. The same report has information on ancillary services and the cost. Ancillary services are labs, culture, imaging, EKGs. Again, care coordination, care coordination, care coordination is very important. It will prevent you from duplication of tests, EKG, imaging. Every category in MIPS is very important. If you participate in promoting interoperability, you might be able to get a CCD from your specialty provider who have already performed EKG or any imaging test. And you can make that part of your EMR, which will help you in future to prevent the duplication of tests. Care coordination in improvement activity, care coordination, there are several ways you can use your care coordination in improvement activity. So again, in MIPS, every category is important. Next slide, please. The same information has the same cost report has information on patients who have visited ER. There could be some ER visits which may not be avoidable, but look into it which are avoidable. Say, for example, a patient who is healthy and visiting ER for UTI. Can that patient be educated to go to urgent care? Or can you make some change in your panel where same day appointments are available? So looking from that perspective would make sense for you. Again, look at this X column, ED, ER admissions. Go back to your percentile, HCC percentile, and analyze, who are high ER utilizers. Are they very sick patients, or they are like, somewhere between medium or low sick patients? Can you make some changes in their habits? So these are some ways I would look at this report. Again, there's a lot of more information on inpatient facilities and, hospice care, post-acute services, which may be hard to change. You may not have control on those kind of things, but these are some things I feel like we can make changes. Physical therapy is there, home health, if patient can use home health versus nursing skilled nursing homes, can those kind of habits, those kind of things can be made changes, would definitely reflect on your total per capita cost report. Next slide, please. Episode-based measure, very quickly, episode-based measure. This report is not as detailed as total per capita cost report. Remember how I was talking about the HCC score? Instead of percentile, here it's a score based. Again, higher means you're dealing with more sicker patients, lower means less sick patients. Next slide, please. So the episode-based measure includes treatment and diagnostic services, ancillary items, service directly related to treatment, and any consequences after the episode, complications, readmissions. Again, I cannot emphasize coordination, care coordination is very, very important. Making sure that patient follows PCP or whoever they are supposed to follow after the episode. Ancillary service, again, care coordination, making sure that there are no repetitions of images or labs. So it's important to focus on care coordination, and episode-based measure, the one focus could be on preventing complications. one thing I really want to touch to make it complete is that there is something called patient relationship category and codes. It is to facilitate the attribution of patient and care episodes to clinicians who serve patient in different roles. Basically, if you use that code, it will help you that if this patient will be attributed to a provider or to someone else. It is voluntary. There are 5 codes. Anyone looking for more information, please contact us and we are more than happy to talk to you all in the detail about it. Next slide, please. And I give over to Sharon.
Thank you, Seema. At a national level, a number of the factors contributing to the high cost of care for Medicare beneficiaries are well known. I'm going to cover just a few of these today to give you some ideas to examine and explore when thinking about ways you can improve your cost category, improve your score. This is not a comprehensive list by any means, but what I'm going to cover today is definitely high on the list. In fact, Seema has already referred to several of these. The first key driver I'm going to discuss is utilization. 2 high cost areas of utilization are emergency department or emergency room visits and hospital readmissions. An estimated 17% of ED visits cost $8.3 billion each year on care that could be spent or provided in a lower cost setting. Hospital readmissions are episodes when a patient who had previously been discharged from a hospital is admitted again within a specific time interval. Often hospital readmissions are preventable events related to complications with the cause of the initial hospitalization or could have been prevented with intervention by the patient's treating clinician or primary care clinician. Another cause of preventable readmission is when the patient does not have a primary care provider and is not getting the necessary post-discharge care. So what are some of the ways you can address inappropriate utilization? First, you can provide information to your patient on where to seek care appropriately, including when it is and isn't appropriate to seek care in an emergency department. We have an example of a patient handout you can use that Natalia is going to drop into the chat box. Seema already mentioned considering building in availability for same-day appointments so you can give your patients an alternative to the most expensive service locations. Another important thing is to know when your patients have gone to the emergency department or they have been discharged from the hospital so you can set up appropriate post-visit or post-discharge care. Often a health information exchange or the local hospital can provide you with a list of patients who have been admitted or discharged from the hospital, provided the patient gives them permission and they have you listed as one of their providers. Additionally, this lets you see who may be visiting the emergency department frequently and repetitively so you can implement care management with them to better control whatever it is that's bringing them to the emergency department. There are a number of toolkits that are available to help you drill into this topic more deeply. And as Seema said, reach out to us and we can help you get your hands on those. Next slide, please. Care coordination can mean a variety of different things, but ultimately it is a patient-centered approach that strives to meet the needs and preferences of individuals while strengthening the caregiving capabilities of families and service providers. Lack of care coordination can lead to duplication of tests or procedures, adverse drug events, and patient dissatisfaction or patient inability to take care of themselves. Care coordination, on the other hand, can improve the patient experience of care by giving the patient the necessary resources and information to best manage their care with the assurance that all of their caregivers are in the know about their plan of care. Excuse me. Some important elements of care coordination are ensure hospitals, specialists, and other providers know you are coordinating care for the patient, so you get follow-up information after the patient has been seen and treated by someone else. There are a number of different ways to accomplish this, but one of the most important is for the patient to understand that they need to provide your information to other providers and to keep you in the loop on their care. This is pretty familiar territory for most primary care providers, so I may be talking to the choir here. For specialists, if you are a specialist, confirm you are asking your patients who their primary care provider is and explain you wish to provide a summary of your findings and treatments to supplement the primary care's provider plan, and that you wish for your care to be in collaboration with what's happening with their other providers. Another good way to put this into practice is to use functionality built within your certified electronic health record. Consistently using the processes to electronically send and receive referrals and summary of care documents will help build a database of diagnoses, medications, and other information from those to whom you have referred the patient or you have received a referral. Care coordination has been happening on multiple levels with programs such as patient-centered medical home and involvement in care transformation programs. There's a wealth of additional information on this topic available. Next slide, please, Nat. According to the Centers for Disease Control, social determinants of health are the conditions in places where people live, learn, work, and play. Examples include safe and affordable housing, access to education, public safety, the availability of healthy foods, local emergency and health services, and the social and physical environments. Excuse me. These factors exist upstream from healthcare providers in that they occur and interrelate with each other to ultimately influence characteristics that manifest downstream in health behaviors, health conditions, functional limitations, and health outcomes. The determinants are now widely recognized as important predictors in clinical care, with positive conditions associated with improved patient outcomes and reduced costs, while conversely, worse conditions have been shown to negatively affect outcomes, such as hospital readmission rates, length of stay, and use of post-acute care. While you may not be able to directly change these determinants for your patients, there are some things you can do. You can collect information about the social determinants of health using the ICD-10 Z codes. Examples of items with Z codes are homelessness, problems related to living alone, disappearance and death of family member, problems in a relationship with a spouse or partner, and many others. Ask your EHR vendor if they have or can incorporate a social determinants of health risk assessment tool in their software to help you systematically collect this information. Once you have this data, you get a clearer picture of the needs of your patient, both individually and as a population. At the individual level, this data can help you direct patients to supportive services within the communities. Understand what community support services are available. Many communities have options under findhelp.org or 211.org or locally managed websites that are a one-stop shop to list all of the support services available. At the population level, using Z codes can help identify trends that have both health and cost implications. Providers can use this data to transform care with integrated services to meet the needs of patients or to speak into community events to address outstanding issues. Like the other key drivers, there is additional information available to help you in this area. The Prepare Toolkit is one example, and Nat is going to put the link for that into the chat box. Next slide, please. Another very important key driver, as Seema referred to several times, is accurate coding. CMS understands the cost of care for Medicare beneficiaries is variable based on age, sex, chronic disease conditions, and social determinants of health. The hierarchical condition codes are captured through coding using ICD-10 codes. Of the approximately 70,000 ICD-10 CM codes, about 9,500 map to 79 HCC categories. The diagnoses must be documented by the clinicians who provide care. A risk factor is then assigned at the CMS level to each HCC category. Additional risk factors are assigned for gender, age, living situation, and Medicaid eligibility. The risk factors scale the expected costs to be reflective of the risks associated with the patient. Use of risk adjustment factors derived from HCC ensures those providers who treat patients with more costly and complex chronic conditions are not disadvantaged in the cost category. So a few important things to know about this key driver. It is critical for clinicians and your staff to understand accurate, specific, and appropriate coding is the mechanism by which you communicate the health and disease state of your patients to CMS. While coding of this nature will not necessarily change payment for services rendered, it will result in the correct calculation of expected costs for each attributed patient used in the cost measure performance results. Additionally, this coding ensures data is provided for the appropriate calculation of the complex patient bonus score, which is part of the MIPS final score. Communication between the coding staff and the clinical staff is important. The coders are a great resource to be able to tell you where more specific data is needed, and they may be able to help develop documentation screens to capture specific level detail. You may also want to consider a coding audit to review your documentation and coding to find areas where you can improve. I hope this quick overview of key drivers gives you some ideas to think about as you review your cost category data. If you want more information or a discussion on any of these, please contact us and we'll put you in contact with the correct support person. Back to you, Seema.
Thank you, Sharon. So I'm going to quickly touch on certain services which you can consider. I'm simplifying this in very simple way. Basically, if you tell CMS that these are the sick patients I have, my patients are very sick, then what CMS does is that CMS puts certain amount of money aside for those patients. And if you stay within that part, then you are doing very well in total per capita cost measure. I really oversimplified, but that's how you can, that's one way to think. So it's very, very, very important to tell CMS that you are dealing with sick patients, and that's where HCC code becomes very important. Annual wellness service is very important. It helps you with the attribution. And this is the time where provider can spend some extra time with the patient. They can update patient's history, patient's medical conditions with proper coding. Look in, if you're already not doing annual wellness visit, look into it. And we have several resources which Natalia is going to post on. If you have any questions about that, please contact us. Transitional care visit, really several studies have shown that it prevents ER visits after hospital admission or any kind of procedure. Look into it. For 2020, when they have increased the reimbursement for TCM visit, telehealth, you can also do TCM visit through telehealth. Chronic care visit, CCM, not very popular because the way the CCM is designed, it's like 20 minutes of staff plus provider time, very hard to keep track of time. But if you do figure this out, if your EMR allows it, look into it. A very good way to do medication management for your certain population. Telehealth. If you are having issues, I'm sure now with COVID, a lot of people are doing telehealth. but just not audio, video, telehealth. There is you can bill if there is certain amount of text exchange has happened. There are within telehealth, there is provider to provider referral, which you can use as get reimbursed for. So look into telehealth. There's a lot of money on the table. Try to use those services. I have been working with CMS. One thing I would say that CMS does not want anyone to be this. CMS is not setting all these for failures. CMS wants everyone to be success. It's just that there are so many various types of practices. So CMS tries to come up with a program which satisfies every different kind of practice. That's why it looks a little complicated. Diabetes management, there are ways you can do diabetes group classes and get reimbursed, I believe, for first 10 hours. CHF, there is, rehab, COPD, remote patient monitoring. There are various ways you can do remote patient monitoring, both for your cardiac patient as well as for COPDs. There are services which requires initial investment, but there are services which does not require initial investment, and you can still bill for it. If you need more information, again, please feel free to contact us. Nursing home patient management is a very big thing which we hear quite often. How do we manage these patients in a clinic? It's quite the if a workflow is not very lean, it could be very confusing. Who is contacting the nursing home? Who is faxing? I have seen that in several practices, they have made changes where only medical director of that particular site would deal with the patients in nursing home, so that the workflow is lean, there is no miscommunication, and issues are handled much more just to prevent the readmissions. After discharge summary, all of us, we know that it's so important for patient to understand when they're discharged from hospital, when they are supposed to follow up, maybe work with your hospital to make sure that they are either helping patient to get the appointment before they are discharged, or they are contacting someone at your practice to make sure that this patient is discharged and you're supposed to follow up. Very important after discharge summary to prevent the readmissions. Referral and follow-up to social service, which Sharon did address quite a bit. If you are in Oregon, Unite Us is becoming very popular. Work with your CCOs to see if you can get free software, access to free software. I have seen several demos, and it's a very good way to handle social needs of the patient. If you are part of OCHIN in Oregon, in Washington, look into it. OCHIN also has a module for the social determinants of health. I would like to say that, all this we are talking because we are Medicare subcontractors, but any of this thing will help you with your all payers and all age patients. So I would like to encourage you all to think, just don't think as a Medicare patients, think as, all payers are paying for this. It is applicable to all categories, and it is really both cost-wise and patient outcome-wise is very, very beneficial. So these are some things which we have seen happening in the field. And if you need more information, please contact us. After hour care is also very important. If your clinic is closed or there's no nurse line, obviously patient will end up in ER. So that's all I have, Natalia, and I'll give it back to you.
Great. Thank you so much, Seema and Sharon and Jeff, for all the great content. As you know, there was so much to cover for the cost performance category, and we know we didn't have time to cover everything today. So before we have some time for your Q&A session, I'd like to pause for just a moment and do a quick poll to get your feedback on whether or not a cost webinar part 2 would be helpful to you. So I'm going to launch this poll and you'll see it on your screen in just a moment. Please give us your answer. And we will move forward on scheduling a second webinar. after we know if it would be helpful for you. Keep this open for just another moment as responses are still coming in. All right, it looks like most of you have ended. I'm going to go ahead and stop this. And there are your results. It looks like both MSPB and episode-based measures would be most important to have a second webinar on. All right, good to know. And I will take this back to the team. Let's go ahead and open things up for Q&A. So we have time for questions from you, the audience. If you haven't already done so, please type in those questions in the chat and we will address them. A couple questions right up front for my presenters. The first one being, do you need to submit data for cost?
Seema, would you like me to take that one?
Sure.
All of the data for the cost measures comes from administrative claims that you submit for payment. So you do not need to submit anything extra through the QPP portal for that cost measure. CMS is going to grab the data that you send in on the claims. So a little bit ago, we spoke about the HCC categories. That extra ICD-10 coding that you put on for those HCC categories, that goes into that administrative claim that you send in for payment. It's not anything extra that you have to submit.
Great, thank you so much. Please remember you can type in your questions now and get those answered. Another question for my presenters, where do I find more information about attribution? Great question.
Yes, it is on QPP website on the resource link, and maybe Natalia, can we email them after this webinar? We can email them, yeah. On the resource tab under cost category, if you click on the episodes, I believe it's under 2018, 2019 cost measures.
Great, wonderful.
Yeah, someone emailed me this question. Would attribution be different for individuals or group, for patients, would attribution be different each year? What they meant, like, the patient which has been attributed to my clinic this year, is it possible that patient may not attribute it to next year? And the answer for that is that, so a little bit complicated. For 2020, attribution methodology has been changed. As we know that they have trying to make it more refined so that the specialty providers are excluded from certain measures. Yes, there's a good possibility that you may not see the same patient for every year, because if patient has changed the provider, or if patient is not, I don't know, patient has not seen the provider, then there's a good possibility, yes, you may not see the patient on the list. But if there are patients who have been seeing for a long time, I would consider them to be showing on the list every single year.
Okay, great. We have just one more minute for other questions, if there are any from our audience. Go ahead and type those in. I know that earlier in the webinar, Tristan had asked about SRA and patient relationship codes, and we put some links in the chat about that. Just want to give a moment. Seema, was there anything else you would say about the patient relationship codes?
All I want to say that we may not have the enough time, but it is at this point, it's very volunteer. It's a good time to get into habit, because this program is not going anywhere. We know next year is the last year for MIPS. Who knows what is coming? So start looking into it, and it will definitely help you with the attribution, especially if you're a specialty provider and dealing with episode-based measures. So first thing, Natalia, everyone should go and look into their cost report and see which measures they have on their cost reports. That's where I would start from, and then look into it. Then we can dig deep into it, and obviously they can reach us out for more help.
Absolutely. That's great information. Thank you so much again to all of our talented presenters. Again, you can reach out to us at any time for more questions after you've looked into your cost scores a bit more. So I'm going to go ahead and wrap us up for today. Please, again, fill out our evaluation survey. We want to know your thoughts, not only on today's webinar, but we want to capture your feedback on topics of interest to cover for future webinars. So we know another cost webinar might be coming, and that's great to know. Look forward to our next MIPS tips officially in January. Topic to be announced. Thank you so much again for participating in this MIPS tips webinar. So if you have any questions, please feel free to reach out to the staff in your state. These are the contacts for the QPP experts for both Comagine Health and Mountain Pacific states. I'm going to pause here for a moment so you can capture that, but it is included also in the PDF of the slide deck, which is available on our website. And I will put both of those websites into chat right now. All right, thank you all so much, and I hope you have a wonderful rest of your day.
Thank you.
Thank you.